some problem, he has to deal with it. And I have asked Professor Fo to act as the first chairman. And before that, I will ask Professor Onjiru to start the opening of the whole webinar. Professor,
thank you.
Professor, please.
Vâng, nanti tolong ambil gambar.
This is Onjiru, President of the Taiwan Heart Foundation. Ladies and gentlemen, this is such an occasion. APSC Cloud Forum. I believe this is the third time.
Yes. So
the title of today is the interventional cardiology. The practices made in this interventional cardiology is fantastic, with outstanding practices, with many breakthroughs. The structural heart diseases to be treated by catheter intervention is ventricular septal defect, atrial septal defect, PDA, pulmonary valve implantation, and the cardiac arrhythmias. I'm grateful to Dr. Lin and our president, Dr. Jack Tan in Singapore. They have organized such a wonderful session today. We have speakers from Malaysia, Singapore, Thailand, Japan, and Taiwan. I believe that today we are going to have a wonderful presentation and discussions. I wish this will be a good success. Thank you very much.
thank you for Professor Lu's opening of the whole section. And we'll ask Professor Fu Chi Chen from Singapore Heart Center to give us to chair the first half of the section of 2 speakers. And we will have Q&A after the 2 speakers. Okay, Professor Dr. Fu, please.
Hi, good morning, everyone. Good morning from Singapore. I'm Dr. Fu from National Heart Center, Singapore. I'd like to thank APSC for the opportunity to chair this first half of this very exciting session, and for providing this platform for learning and interaction during this extremely difficult COVID period. We have 2 esteemed speakers on 2 exciting topics coming up. The first speaker would be Dr. Mahisham. He is a consultant and the head of the Pediatric and Congenital Heart Center, National Heart Institute in Kuala Lumpur, Malaysia. And he will be talking to us and giving his enlightening us on this interesting topic about transcatheter closure of VSD in adults. Dr. Mahisham, over to you.
All right. Can you see the slide?
Can see your slide.
All right. All right. So I would like to thank you, organizing committee, for this opportunity to share with you all on this topic of transcatheter VSD closure in adults. I probably not the best person to speak on this. I think Warakan may have much more experience in VSD device closure. And however, I will try my best to give justice to this topic, and I will share a few cases to illustrate the indications of transcatheter VSD closure in adults. So this is a case one, a 20-year-old gentleman who has been under our follow-up since childhood for ventricular septal defect. He was otherwise asymptomatic with good dental hygiene, but noted to have a worsening tricuspid regurgitation on the follow-up echocardiogram. And you could see on the first echo pictures, so there is a perimembranous ventricular septal defect with aneurysmal tissue covering and the jet directed into the tricuspid valve. And on the second echo, you could see a single ventricular septal defect with a possibility of two exit points, and the second jet directed into the tricuspid valve, causing so-called worsening tricuspid regurgitation. And on the third pictures, the still picture of the measured ventricular septal defect showed a funnel-shaped ventricular septal defect with the measurements as stated, and the narrowest diameter was 5 millimeter. And the hemodynamic study was performed earlier on, and there was a borderline shunt calculation. QPQS was 1.4, and standard LV angiogram showed almost similar with similar shape of the VSD on the transesophageal echo. And on the lateral projection, you could see a long funnel-shaped VSD over here. All right, and then luckily it was easily crossed by the guide wires, but however, the AV loop was difficult to be established multiple times. So I believe it entangled the tricuspid valve. So we decided to close the defect retrogradely. So as a safety mechanism, I usually park a coronary guide wire across the defect into the pulmonary artery. So it behaved like an insurance. So just in case I may have trouble with the device and may need to recross the defect. So the multifunction occluder size 10/8 was delivered retrogradely, and the position confirmed with a transesophageal echo and LV angiogram. And the device then was released and followed by release of BMW guide wire once the position was confirmed. So the final LV angiogram showed a good device position, and the aortic valve was much away from the device. And on the TE, you could see there was a good device position with no residual shunt, and tricuspid valve was much reduced. Tricuspid valve, I mean the tricuspid valve regurgitation. And the aortic valve was fully competent with no aortic insufficiency. So when we talk on the VSD in adults, I think it is good for us to know the natural history of a ventricular septal defect. One of the earlier paper by Coron and colleagues that was published in June 1977, and I believe some of you might not even born, and a few long-term complications were observed, namely aortic regurgitations, which observed in 6.3%, bacterial endocarditis, congestive heart failure, 3% of mortality, and also increased pulmonary vascular resistant pulmonary arterial hypertension in 82 cases. And not to forget, a significant number of RVOT stenosis observed in 21% of patients above 30 years old. The AI occurred in outlet type of a ventricular septal defect, even in perimembranous type. And talking about bacterial endocarditis, it might not be high in certain countries, but in developing countries, like Malaysia and probably in Southeast Asia, it remains significant even until now. And the majority of the ventricular septal defect remain stable, which is observed in 71% of total 790 cases, and 40% had a complete spontaneous closure, and 7% had partial closure. So there are three groups of indications for the device closure. I believe the first one is the congenital type, and the second one, it can be iatrogenic or as a post-op residual VSD. Iatrogenic could be such as a complication after surgical aortic valve replacement, transcatheter aortic valve implantation, septal myectomy for hypertrophic cardiomyopathy, or even from erosion of a strut of a bioprosthetic mitral valve. And the third one, I think, in the post myocardial infarct ventricular septal defect, or sometimes they call it ventricular septal rupture. In IGN, we close about 78 VSDs for the past 3 years. And for me, looking at the VSD in adult by percentage, it was a big percentage, I suppose, for congenital VSD. But it was simply because we used not to close small VSD in the past. The reason was because of very limited device option. A stiff device may be troublesome, and the complete heart block was the main concerns back then. All right, so I will not go into detail for this group as the first case has already illustrated the closure in the congenital group. So, but I would like to highlight that the group of patients that we consider for transcatheter closure are those with mid or apical or muscular outlet VSD, or even in perimembranous VSD. We do not perform transcatheter closure in subarterial type of VSD, and of course in those with other surgical considerations like RVOT stenosis, mitral or aortic valve regurgitation. So let's go through the second indication, those with iatrogenic VSD or post-op residual VSD. So this is a 24-year-old lady who presented with respiratory symptoms and diagnosed in childhood as a ventricular septal defect, but the parents refused surgery and defaulted the treatment. So this lady presented again at 23-year-old with chest pain, and clinically she was pink with regular pulses, no finger clubbing, hyperdynamic precordium with a significant parasternal heave, systolic murmur at the left lower sternal edge with loud P2, and the liver was not enlarged. So you could see the first echo, which showed LV dilatation, and the second echo showed large ventricular septal defect with a bidirectional shunt, and same with the third echo, which showed large perimembranous VSD with a bidirectional shunting, and no significant RVOT stenosis. All right, so this is her chest X-ray presentation. We showed cardiomegaly with cardiothoracic ratio of 0.7 and dilated pulmonary trunks. So we brought her to the lab, and hemodynamic study was done. And you could see the hemodynamic here. Aortic saturation was 98% with PA saturation 86%. With PA pressure is almost systemic. Okay, this is a mean of 78. QPKS was 3.5 and PVRI was 8.2 unit, Woods unit. And no changes of PVR with 100% oxygen. So given the history and the findings, I think what should we do? So to cut the story short, we had our multidisciplinary team discussion, hence decided that the surgery was still feasible despite systemic pulmonary artery pressure. So we thought the fenestration was necessary as a blow-off, And this lady was primed with sildenafil before surgery and continued after surgery. So the fenestrated VSD surgical closure was done. We were actually preparing for the worst case scenario like a pulmonary hypertension crisis or whatnot. But she was doing so well after surgery and discharged very early at post-op day 5 with sildenafil monotherapy. And on the echo, you could see a nice fenestration created by our surgeon. And on the second picture, you could see the measurement was about 4 to 5 millimeter, and you could see it's away from the aortic valve. So she was under our regular follow-up till after a year, 1 year, and we decided to restudy her hemodynamics and plan for VSD device closure. So her hemodynamics was very fantastic. PA pressure was only a mean of a 19, and PVR was a 2.6 Wood unit. So we closed the VSD. The AV loop was established, and the ADO2 device was delivered integrately, closing the fenestration. And the final angiogram, you could see good device position with no aortic insufficiency. So the TE also showed a good device position with no residual shunt, and there was trivial tricuspid regurgitations and no significant aortic regurgitation. And we could observe a tremendous changes of the serial chest radiograph, and we could see the changes of the heart size as well. The size become smaller, and also the vascular markings become less prominent. She is basically now back to her work, become more cheerful, and now on the tapering dose of the sildenafil. All right. So this is the third indications for transcatheter closure in adult. Those who has a ventricular septal rupture or post-infarct VSD secondary to acute myocardial infarct. So this is actually one of the 3 major mechanical complications of acute myocardial infarct, other than mitral regurgitation and free wall rupture. And this incidence, 1.3% actually before the thrombolysis era. I think nowadays, most of the paper quoted that the incidence of post-infarct VSD is much lower, less than 1.1% or even less than 0.5%. And the predominant cause actually the LAD, which is 42%, and also RCA, which is about 46%. And it believed to be due to reperfusion injury that may result in hemorrhagic infarct, leading to early VSD development. And the defect is most often at the apical septum in anterior MI, and at the base of the heart after inferior MI, and may also involve a free wall as well. It has a very high mortality rate, and if left untreated, as high as 94%, as highlighted in AHA guideline 2013, and the mortality decline with delay of repair of VSR. All right, so let us go through this case 3, a 60-year-old gentleman who was admitted for acute MI. Initially planned for the bypass surgery, but for some reason we decided to go ahead with percutaneous coronary intervention, stented the LAD with 2 stents. So this is his echo. It was basically quite well, but however, on the daily rounds was noted to have pansystolic murmur. And truly enough, on the 2D echocardiogram, we could see an apical VSD left to right shunt. So again, the MDT was done in between the cardiologist, our surgical colleague, and also pediatric interventionist. So we decided to close the VSD transcatheterly due to an atypical issue, which very remote. And the procedure was done pretty early, about day 5 post-infarct. So you could see the LV angiogram, which showed moderate size of VSD, and the AV loop was established. The Amplatzer muscular VSD device size 8 mm was delivered antegrately. All right, on the 2D echo, you could see a good device position with a small residual shunt on the echo with a good ventricular function. The man was quite well after procedure and was discharged after a few days. He was quite committed to follow up. So this is the assessment a few years later, which showed very good LV function, and the device remains stable in good position with no residual shunt on the Doppler. So post-infarct VSD, I think AHA guideline 2013 has highlighted the gold standard recommendation for surgical closure in stable patient, especially with those with preserved end organs and also suitable anatomy. And they recommend to delay the surgery due to concerns of necrotic tissue fragility and inability for the repair. And the transcatheter septal closure is reserved for those who are stable with a difficult anatomy or those who are too sick for surgery. What remains controversial is the timing of procedure, but most of the time in our institution, we do it after 1 week of infarct, considering the granulation tissue has taken place and also strengthen the defect margin. All right, so this is an example of case 4. A 59-year-old lady was referred for acute MI, complicated with end organs failure. So the initial LV angiogram showed a relatively large apical ventricular septal defect. So it's very apical. So we thought the best approach for this patient is via the neck vessels. Hence, the AV loop was established via the internal jugular vein, and the Marlin's sheath was advanced and parked into the left ventricle. So, as I mentioned before, the VSD was relatively big. So, measured the narrowest point is around 16 mm. So, we decided to use Amplatzer atrial septal defect occluder, which was delivered anterogradely. Yes, we observed a residual shunt after the closure, but the device was in a good position. So we decided to leave the residual shunt and observe. But truly enough, the patient remained unstable, had significant residual shunt on the subsequent days after the procedure. So after the discussion, we decided to go ahead with the second closure, but we delay a little bit after 2 weeks of the infarct. So this is the LV angiogram. We showed the first device position. There was a residual shunt below the initial device. So the defect was crossed using coronary guide wire and was later changed to Terumo exchange guide wire and was pulled into the internal jugular vein. So this is the second, the Marlin sheath across the defect below the previous device. And we deliver another atrial septal occluder into the second defect. So this is a final angio after the final occlusion. And again, we decided to leave the residual shunt. Okay, so I think this is the same angiogram as showed before, but the good progress, this patient was stable post-procedure, recovered all the end organs functions, and was discharged home days later. And this is actually the follow-up echo. We showed good LV function, and you could see the device on top of each other, with no significant residual shunt and good ventricular function. So should we worry of residual shunt? Yes, I believe if let's say the defect is large and the end organ function may not be recovered fully, and I don't think we should worry if the residual shunt is small. We should not oversize the device, considering the cascade effect of the necrosis if this later on will lead to device embolization. And in fact, in the serial review on the post-infarct ventricular septal defect closure, we could observe actually a significant number of residual shunt post-procedure. So if you see all these papers, actually it's more than half, it's 60% has a residual shunt. And not surprisingly, the residual shunt from surgical closure was about the same rate. And we believe that physiologically, the tissue remodeling will likely partial or completely close the defect in the near future. So my mentor, Dr. Oliver Stamper, always taught me that perfection is the enemy of good. So leaving the residual shunt probably is acceptable for this group of patients. So ladies and gentlemen, as a conclusion, consideration of a transcatheter closure of a congenital VSD in adults must include the natural history, which is the high incidence of endocarditis in developing countries, and also high incidence of late RVOT stenosis, AI, and also increased pulmonary vascular resistance. And transcatheter closure of VSD is an accepted alternative to medical therapy or surgery for acute post-acute MI ventricular septal defect. And definitely a multidisciplinary team approach, including interventionalist cardiology and also cardiac surgeons. We should evaluate these high-risk patients to determine the optimal management strategy. And we need to accept some residual shunt. And the principle is perfection is the enemy of the good. So with that, I thank you.
Thank you, Dr. Mahisham, for the very enlightening talk and the very interesting cases that you have shown us. I'm sure everyone is very eager to ask him questions, but in view of the time constraints, we will defer it to our subsequent Q&A after this. I would like to introduce our second speaker, Dr. Warakan. He is the head of the Pediatric Heart Center in Bangkok, Thailand, Queen Sirikit National Institute of Child Health. He has an interest in transcatheter closure or perimembranous VSD, as well as pulmonary valve implantation, in particular using the venous P valve. He will give us a talk on the transcatheter closure of VSD, as well as ASD, as well as PDA in adults. Dr. Warakan, please go ahead.
Thank you, Dr. Cheng. Can you hear me and see my slide clearly?
Yes, I can hear you very
okay,
well.
Thank you, sir. And first of all, I'd like to thank Professor Liu and also Professor Lin, and also the APSC organization committee allow me to be part of this wonderful cloud forum of the society. So I hope that I can do my best for this. So this is my disclosure. And so let's start with the PDA in adult. just to show you, this is the latest guideline from the AHA, showing that in terms of the diagnosis, the major issue would be you need to see whether the patient has Eisenmenger physiology or not. So if you see purely right to left shunt across the ductus, I think it's not a good idea to close it. And also, if you are considering that the patient has severe PAH, you need to check whether it's reversible or not. And that's the key thing that you need to check by either doing the catheterization or even try to treat and then repair again. In terms of therapeutic indication, I won't go through this, but again, just to re-emphasize that you need to see the PVR, whether or not it's reversible. You need to check the pressure carefully and make sure that what you are doing is actually useful and also helpful for the patients. So I'd like to say that in terms of the assessment, and you need to divide into two groups of the assessment. The first one would be you need to check for the physiology. For the PDA, of course, you deal with the pulmonary hypertension in many cases. And also sometimes you may find the patient with a PDA left over until the patient become elderly. In terms of anatomy as well, even if the physiology looks fine, but sometimes anatomy, you can't well identify how does it look like. And also you may have to deal with the calcified duct. And also, if I have can say something about the elderly, that would be a good example to show that it's not really similar to adult or young adolescent patients at all. So let's start with this angio. So of course, as you can appreciate that even if we get a good angulation, even if you have a good injection quality, sometimes you'll not be able to see the ductus very clearly by angiography. So that's the main reason that as an interventionist, as the operator, you need to deal with this kind of issue many times. Poor image quality, you need to give more shots, more contrast, and the patient may complicate it with renal insufficiency because contrast induced nephropathy sometimes. And also because of the high pulmonary artery pressure, so that's why you can't see the shunt left to right shunt very clearly from this injection through the aorta. And with that, it's very difficult for you to decide whether is it justified to close, or if you want to close, what size and what type of the device you're going to use. And obviously, with this kind of uncertainty, it may run the risk of complication afterward. So with that, in terms of injection, at least you need to have a little bit of modification. So I will always use largest diameter of the pigtail catheter. So that allows you to give a large shot of the volume in a very short period of time. And of course, you need at least 40 cc, 35 to 40 cc of contrast media. You need pressure high enough, at least 700-800 psi. And most of the time for the PDA, if possible, I will try to see in the different angulation. First one would be RAO crane, RAO, and then second one would be like lateral 90 degree. And the frame rate also important. If you use a frame rate for the PCI setting, sometimes you may not be able to see the ductus very clearly. And even if you do that, it's better because if you can check it previously before you bring the patient into the cath lab, that would be very easy for you to make decision. And this is one of the benefits using the cardiac CT to guide you through the process of the make decision making of how to close or should you close the ductus percutaneously or not. And thanks Dr. Subipaporn and his colleague from Normativity Hospital allow me to present this kind of very nice CT imaging. Again, just to show you, this is a conical shape of the ductus with some calcification here. And that's, I'll address this later on, but this is the thing that ring the bells for you that probably this is not a very straightforward case to deal with. This one is also quite short ductus arteriosus. Again, with this, it may give you some ideas before you bring the patient into the cath lab, whether how or what should you deal with this. So let's go back to the angiogram. Again, because of this uncertainty in terms of the delineation of the anatomy, you need a little bit of modification. And one of the good things using the sizing balloon or balloon interrogation is to at least checking whether anatomy, how does it look like, and also you can understand the physiology much better by using this kind of balloon. Again, just to show you now, you can see the ductus diameter very clearly, how big it is, what is the size. With that, it's easier for you to make decision what side of the device you're going to use. And also sometimes you can use not just the ASD sizing balloon, but also the balloon, peripheral balloon or balloon valvuloplasty, just to interrogate this kind of anatomy. And that will allows you to make a decision what side of the device would be good for this particular case. And also not just anatomy, but also physiology. This is a patient that very big PDA. And again, when you see the angio, you see it's bidirectional flow. It's not purely left to right shunt. So with that, you may considering whether you should close it without any treatment, or you should interrogate it properly by so-called the treat and repair or whatsoever. So with this, it's easier for you to delineate your treatment approach by just put the balloon in. So when you occlude the balloon, as you can see, sorry for not very high resolution image, but yeah, just to show you, when you occlude with the balloon, the PA pressure drops down a bit. But once you give the oxygen, and also once you give the iloprod plus inhale iloprod, the PA pressure drop very obviously. So with that, it gives you at least a bit confident just to close this kind of defect. And this particular case has been successfully closed by the muscular VSD device. Just in case that PA pressure is increasing, then the device will not embolize to the aortic side. So this patient, actually, we did prime with the sildenafil, and also we continue sildenafil as Mahisham also addressed in some patient, some VSD patient that he presented. Another thing that I would like to address is a calcified PDA or calcified aorta. This is a patient, this is quite, probably this is the oldest patient reported, about 92 years old patient presented with PDA. So the doctor in Japan, so they decided to close with the PDA device because of the clinical significance of the heart failure. But again, just to show you that with the CT imaging, it'd be easier for you to at least have a look whether how much of the calcification of the calcium that may cause an issue of when you put the device in, because the area where the calcium is in will not expand. So with that, sometimes even if you oversize the device, if the calcium is covering all entire the ductus, it may not, your device may not oppose very nicely with the ductus. So that may cause a residual shunt. And even if you oversize it, it's not really helpful in terms of the abolish of the residual shunt. And with this kind of ductus with calcium, the surgeon is quite reluctant to go as well, because it may cause them a rupture when they try to ligate it. So most of the time when the surgeon deal with the calcified ductus in older patient, they may consider to go on bypass and then try to patch either from the pulmonary artery side or aortic side, rather than just ligate it or divide it. Let's have a look on this patient. This is a patient that, as you can see, sorry for the image which is not centralized, but just to show you that there's a calcium here, and also there's a purely left to right shunt across a PDA, which is not really big in terms of the diameter in relation to the size. So the measurement probably about 8 to 9 millimeters. But again, just to emphasize that there's a calcification in the ampulla and also in some particular part around the ductus. This patient, we didn't do the CT imaging, but we that time decided to put the largest ADO1 that we had which was 14/16. And as you can see, that immediate after we implant the device, it does a residual shunt. And you can predict that in the next few hours, this happens. So with that residual shunt, even if the murmur is not so noisy, about grade 2, but it's it's much enough in terms of the shunt to create a hemolysis. So this particular case, we decide to go back, try to occlude the residual shunt here by just puncturing the wire through this kind of this, and then try to put another device, but unfortunately we could not make it. So we eventually asked our surgeon to deal with that surgically. So surgeon eventually can deal with this very nicely without any problem. And also this is a report, aortic dissection after duct occluder, epidemic closure in the elderly. This is probably about 70 years old patient, which quite long tunnel and very elongated, and also distal constriction here. So the operator decided to put the AVP2, which is quite reasonable to deal with this kind of ductus. And as you can appreciate that in the next few days, the patient had the chest pain and then caused dissection very badly all through the descending aorta from ascending aorta. So eventually the surgeon deal with that by using the stent graft to deal with this kind of type A dissection. Well, just to show you that again, the elderly ductus is not similar to the adolescent or adult ductus at all. So be careful with that. So now let's deal with the PDA, ASD. Again, physiology, you always deal with, PAH or restrictive physiology of the left ventricle when you have to treat this kind of ASD in older patient. And arrhythmia sometimes may an issue as well. Anatomy, of course, you probably need to deal with the deficient REMS. You need to deal with the malaligned septum, and you many times you deal with the large defect. So let's have a look on this guideline once again. This is a guideline written, published just recently by AHA, but just to emphasize that they need to check again whether this is purely left to right shunt or is Eisenmenger physiology. Is it purely right to left shunt? I think there is no issue on trying to closing it. But if it's kind of borderline, it means that PVR is about 1/3 of systemic, or pulmonary artery systemic pressure is half systemic. So in that particular case, you need to be very robust in terms of the assessment to deal with this. And sometimes you need some special issues to or special kind of approach to deal with this kind of problem. Just to show you the case, thanks Supa and her team at Prince of Songkhla University sharing this case during live transmission in 2017 with TINS at the TINS meeting. But just to show you, 40 years old female, the patient saturation was still okay, but looks as if when the patient on exercise, there's a little drop of the saturation. NT-proBNP is not dramatically high, but it's not normal. And again, as you can appreciate, that peer pressure likely to be higher than usual, but it still looks as if there's a little evidence of showing the large left volume overloading. So with that, esophageal echo showing that the ASD is not really that big. Okay, so Supa and her team decided to bring the patient into the cath lab just to test. This is a thing that we need to be very careful, and we need to be very considered to do in a borderline case. So she started with using a room air condition testing, and as you can appreciate, that peer pressure and aortic pressure looks similar in terms of the systolic, but the diastolic looks as if the peer pressure is lower. So that's to me showing indirectly that the PVR somewhat is kind of reversible. And then she gave the oxygen 100%. Again, saturation increased QPQS I'm not showing with this because of the interest of time, but just to show you that peer pressure is slightly decreasing, especially for diastolic pressure. And then she also tried to distract the patient with the butyl dopamine. And again, systolic pressure is quite high and actually is higher than systemic pressure. But just to emphasize again that diastolic peer pressure is quite low. Last but not least, she tried to include it with the ASD device. And again, peer pressure and aortic pressure is quite different. Aortic pressure, it's not much different, like 150, and actually looks as if the peer pressure is a bit higher than the aortic pressure. So again, this is kind of borderline case. With this, she decided to prime the patient with this sildenafil and also bosentan, I think. And then after 8 months of the treatments, she brought the patient back into the cath lab and customized an ASD device that she's going to use by telling the company to please make a hole for her. And then the cognitive company decided to make the fenestration about 6 millimeter in the device. And here's the device in the patient heart. And then as you can appreciate that there's a shunt still here, which is actually left to right shunt, and the hole is here. So again, this is a thing that you can use the device just to help the patient in a borderline case. Of course, it is not always indicated in all the cases. You need to tailor the patient according to the physiology and anatomy. And here's another patient I'd like to show, which is quite important for me to address. 62 years old, presented with a dyspnea on exertion, a functional class 2. We found the patient had secundum ASD about 17 millimeter. The choreoangiogram appear normal. I'm sorry I didn't show you, but please believe me on that. Chorial artery looks normal. So again, the hole doesn't look that big, and the size actually quite not that round, but at least it's not so much huge diameter. This is aorta, SVC is here, IVC is there. So it looks as if the hole is not that big. One thing that keeps ring the bell when I see the hole, which is not big, but the patient has a significant symptoms, is we need to very careful on that, especially for the elderly patient. Because the degree of direction of the atrial shunt depends on not only the size, but also the different compliance between the right and the left ventricle. So what does it mean? It means that if the LV compliance is worse than the RV compliance, the shunt here is going to get much more obvious. And also, if you have like ventricular inflow obstruction either on this side or on that side, the shunt here will be even more preferential. Let's say if you have mitral valve disease, mitral stenosis, and then the shunt here going to get bigger. So in this particular elderly, not much elderly, but 62 years old patient, which has a lot of symptoms in comparison to the side, isn't really relevant. So with this, you need to very careful checking the diastolic dysfunction. And again, LV EDP initially was about 18. And then, so Dr. Shayasit from Konkan, Konkan University Hospital. So we decided to put the balloon just to test occlusion on that, and in order to see how does the LV EDP behaves after we partially blocked it. And again, just to confirm that this is very striking of the increasing LV EDP from 18 up to 32. So of course, this patient is not really just an issue of the ASD left to right shunt, but also an issue of the LV diastolic dysfunction. So with this particular setting, we need to deal with this first and then try to bring the patient back again in order to see whether if we blocked it, that LV EDP will get obviously increasing like this or not. And again, this may be an issue that we may need to use a fenestrated device in the future to close it. And also an issue of the septal alignment. Just to show you, in general, the alignment of the atrial septum should look like this. So it should be like a coaxial plane from the atrial septum through the commissure between right and left coronary cusp, and also the pulmonary artery and pulmonary valve should be like this. But sometimes the patient may have a leftward malalignment, and sometimes the patient may also have a rightward malalignment. So how important of this, I will show you. Thanks for Dr. Rio Okura showing this very nice picture of the separation of the septum primum and secundum and causing malalign of the interatrial septum like this. So this at the moment, when we deal with this, we have to consider whether that patient may have difficulty in terms of deployment, and also in the long run may relate to erosion. I'll show you, and again, thanks for Dr. Teiji Akaki showing me this case and also allow me to present this since 2012. But I'd like to address that this is a patient, again, malaligned septum, and as you can appreciate that the exit in normal patient to be like this, but for this particular case, it's like that. So with that, when you put the device in normal alignment, there'll be no issue because it's symmetrically pressurized the aortic root like this. But for the patient with this malalignment and deficient aortic rim, so that may, causing the just focal pressure to the aortic root like that. And sometimes if the rim here also deficient, it may pressure the aortic wall here. So this particular case actually, as you can see, after device release, there's an obvious pressure here at the aortic wall on the right atrial side. And also this is the case, thanks to Dr. Napa, my colleagues from Ravati Hospital, showing that this patient also had an issue of the aortic to the right atrial tunnel because of that kind of malaligned septum, and there's a pressure on the aortic wall here. And this patient above actually had the pericardial fusion developed just a few days after implantation and need surgical removal of the device. And because of that malalignment, and the surgeon just found the hole here at the site of the right atrial disc. So again, the erosion is an issue, and you need to be very careful when you deal with malaligned septum and deficient aortic rim. And also, if your defect is so high, higher up near the SVC, because that area is a potential space that you may run the risk of the pericardial fusion, rupture into the pericardial space. And last but not least, I would like to show you in genetic population, probably this is the largest number of showing that elderly patient aged about 75 years got a benefit of closure ASD, especially for the New York Heart Association functional class, and also BNP level decrease, well-being improved, and also the tricuspid regurgitation improved. So in elderly patient, closure ASD is quite helpful. So in conclusion, ladies and gentlemen, I would like to conclude that when you deal with the PDA and ASD in adults and you try to close it with the device, patient selection is a major key of success. And you need to concern not just anatomy, but also physiology of the patient. And every patient is unique. So please tailor your treatment with each particular patient. And last but not least, you have to prepare for possible complication. So thank you for your attention.
Thank you, Dr. Warakan. Hi. So thank you for highlighting the specific patient subsets where we have to be more careful when we are doing ASD as well as PDA device closures for these patients. We are running a bit short of time, but we will have a quick question and answer just for these two topics before we move on to the second part of this webinar. I would just like to ask Dr. Warakan, With your experience in ASD device closures, sometimes we do see a significant number of patients with documented nickel allergy, especially on patch testing. And in such patients, we know our usual devices, such as the Amplatzer device or the Occutech devices, they have a significant amount of nickel, which might cause allergic reactions and all that. I just want to ask about your experience in this. Do you still go ahead to use the usual devices, or do you use the GORE device, or do you send them to the surgeons to close the ASDs in such cases?
Thanks for the question. So first of all, I never do allergic testing for nickel before the procedure. So that's one thing. So I may miss some of the cases. But there are some patients that had history of nickel allergy. But with that, we most of the time continue with using just regular Amplatzer device or like Amplatzer-like device as well. So there's a case or some cases with history of headache or some kind of not feeling well after device closure. So I'm not sure exactly whether it's related to the nickel allergy or not. But to answer your question, in my experience, I would say that there is not big issue for nickel allergy. And I think at the moment there are some device company that try to reduce the kind of nickel releasing in the bloodstream by coating with the either platinum or the titanium or whatsoever, just to try to reduce nickel latching. So that may help. But again, I don't think this is a big issue. So please, if Hisham or other speaker panelists can share your experience with us.
I have encountered just one patient with known to have a nickel allergy, and with a large, so moderate size atrial septal defect. And I think at the end we sent the patient for surgery. So I think I would rather avoid the complications of serious complication of nickel allergy rather than subject the patients for the device closure.
Okay, thank you very much. I would just like to add that, I mean, the GORE device is not commonly used in this part of the world, but it does have less nickel content than the usual devices that we use, such as the Amplatzer device or the Occutech. So I think that can be an option in patients with confirmed nickel allergy as well. I'd like to ask Dr. Mahisham. Thanks for the very interesting examples about those patients with post-MI VSD. I'd just like to get your opinion on what you feel about what is your thinking process when you are actually choosing a device for patients like that. When would you actually choose the ASO device, like in the case that you actually presented? Or when will you use a muscular VSD device or a post-MI muscular VSD device?
Now I think we don't have much option in terms of Amplatzer muscular VSD device. And the problem with a muscular VSD device is very stiff, and for you to oversize, to aim to close the defect completely is probably a bit difficult. You have to precise measure the defect properly, and then you should not oversize when you close the defect using muscular device. But for ASD, I believe when we use ASD device, we have a lot of option in terms of ASD device. And some of them is a bit low profile as compared to the other. And then in large defect, especially without a proper defect margin, then I would prefer to use atrial septal defect occluder rather than muscular defect. Those with very well demarcated margin of the VSD post-MI, then muscular device would be a better option.
Okay, thank
And
you.
most of the time, the cases that refer to us, I think by our adult cardiology, and we tend to actually close the VSD dose with a very sick, or there's no other option, especially because most of our colleague will send the patient for surgery if the patient is stable.
Dr. Warkan, you have something
May
to
I have
add?
a question? Yes, to Hisham. Thank you. So Hisham, that's very challenging case. I mean, the VSD that you post-infarct VSD, I saw some aneurysm at the apex, you know, my worry. I mean, if I were you at that time, would be, you know, if I put the device which is so apical, it may rupture that kind of aneurysm. So, in your opinion, in what particular post-infarct VSD that you would not try to close it?
First, I would think it's patients who is a very, what do you call it? First, of course, patient with the other comorbidity. And then, let's say, I think the patients that we showed, actually a patient with renal impairment, but because of there's no other way of closing the defect, then we take the high risk consent and proceed with the surgery. And the second case, the first case was, I think, was quite straightforward. But the second case for me is probably a bit challenging. And actually that patient was referred from the other center. And then again, there's no other option. So myself, and I think at that time, I think Mazni was thinking of either close it or just leave it. So yes, both way will be a challenging, right? Either you leave it, patient might not survive because patient is very ill, or just this is a 50-50 chance of closing the defect and helping the patient, and we take that 50 chance rather than leave it the patients alone, and you know that the mortality for VSD post AQMI is so high, is almost 80 to 90%. So I think that's in between the chances of surviving post MI, and another thing is either you leave it the patients just like that.
Thank you. It's very, very difficult to make decision.
Exactly. Yes. Yes.
Thank you, Dr. Mahisham. Thank you, Dr. Warakan, for the two interesting lectures. Are there any other questions? If not, I think in terms of because of the time constraints, we will move on to the second part of the talk.
Thank you.
Yes, since Professor Wang is not back to the scene, I will just transfer the chairmanship to Professor Wang again. Professor Wang, please.
Okay, thank you. It's my great pleasure to be the moderator of this section. The first speaker is Dr. Min-Tai Lin. He's a well-known interventionist. Also, he's interested in Kawasaki disease. He has a lot of publication and experience in interventional procedure. He will talk about the percutaneous peripheral valve implantation experience in Taiwan.
Can you see this slide, everybody?
Thank you, Professor Wang. Good morning, ladies and gentlemen. This is Dr. Lin from Taiwan. First, I would like to thank the organization committee to invite me to deliver this talk. Today, my topic is percutaneous pulmonary valve implantation, Taiwan experience. Here is the outline today. First, I would like to mention the impact of pulmonary valve regurgitation. I will take tetralogy of Fallot as an example. And the second is describe such a patient when they enter into adulthood. And the third is regarding to the timeline of PPVI in our hospital. And then I will show you three typical cases regarding to using melody valve, venous P valve, and the push-start valve. And I will also show you the midterm results of follow-up and then future directions and summary. As you know, the tetralogy of Fallot, including 4 major defects, including VSD, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. The incidence of tetralogy of Fallot in Taiwan is 0.6 per 1,000. That means each year in Taiwan, in this island, we have around 120 new cases of tetralogy of Fallot. Usually, such cases had their total repair in infancy, and the mortality rate is very low, less than 1%. And the insurance data have shown us the adult population has become larger than the pediatric group. So after patch repair, the patch repair in tetralogy of Fallot may cause a chronic pulmonary regurgitation, and the chronic pulmonary regurgitation may cause dilated right ventricle and then heart failure. Previous studies have also showed the long-term survival of repair tetralogy of Fallot. You can see the survival decreased gradually, and the slope had significant changes at 25 years after total repair. If you look at the arrhythmia attack in the population of tetralogy of Fallot, you can also appreciate those aged around 50 years old. They have a 10% of arrhythmic attack, and such event is associated with chronic pulmonary regurgitation and RV dysfunction in this population. So the solution should maybe the surgical or percutaneous pulmonary valve replacement. Regarding to timing and the indication, the AHA guideline suggests for symptomatic patients, they have a class 1 indication to receive pulmonary valve replacement, surgical or either surgical or percutaneous. But for a symptomatic patient, the criteria is still under debate. For example, the AHA guidelines they recommend for a symptomatic patient, they suggest some volume guideline or a volume criteria or pressure criteria or exercise intolerance for the inclusion criteria for such patients. In our hospital, we set such eligible criteria, including symptoms, age, body weight, and severity of pulmonary valve regurgitation, and also some volume criteria and the electrical cardiographic criteria. And in Taiwan, the patient should they need to pay the expense of the valve by themselves. So far, the available devices for PPVI are classified into two major groups. The first is balloon expandable, including Medtronic Melody valve and the Edwards Septium valve. And the second is a self-expandable group, which includes the venous P valve, harmonic valve, and the push-start valve. And right now, in Taiwan, we only have these three valves available. About the timeline of PPVI in our hospital, in 2015, my mentor, Professor Wang, is also chairman of this section. He started the PPVI with a handmade pulmonary valve, which is originally of aortic aneurysm graft, and we have a help from the surgeon. The surgeon use their hand to make the so-called handmade pulmonary valve, and then we did the pulmonary valve implantation. And then at the end of 2015, we had a Medtronic Melody valve, and 3 years later we have a venous P valve. And last year at the end of last year we had a push-start valve from Korea. About the results, so far we had 34 patients who had a percutaneous pulmonary valve implantation. Next slide, I will show you some demonstrate some case and also midterm follow-up results. Case one is about the Melody valve. The Melody valve is a bovine jugular vein valve, and the frame is composed of a platinum iridium frame. She is 29 years old lady. She had a congenital corrected TGA, VSD, and pulmonary atresia. She had a conventional repair at her age of 4 years, and suffered from recurrent PS, and had repeated balloon dilatation and redo operation. She suffered from pulmonary valve regurgitation, which caused right side left ventricle progressive dilatation and exercise intolerance. Here is the appearance of a Melody valve, and we crimp the valve on the assemble system, and then advance the whole assembly into the heart. Here, the left side video show you the compromised right side left ventricular function, and the left side video show you the moderate to severe pulmonary valve regurgitation. Let's see the cartoon to show you how to assemble the venous P valve system. When you can advance the whole assembly to the level of pulmonary valve, then pull back the outer sheath, inflate the inner balloon and also outer balloon, then you finish the procedure. So let's go back to the real world. For this patient, we should do we did pre-stenting first. By using a big balloon together with a 45mm CP stent, and then we advance the whole Melody valve assembly into the level of pulmonary valve, inflate the inner balloon, outer balloon, and then you can see the MPA angio show the very good results with a very trivial pulmonary regurgitation. And second case is about the venous P-valve. She is a 12 years old the girl. She had a native dilated right ventricle RVOT together with a severe PR. As you know, Melody system is only for 20 millimeter and 22 millimeter pulmonary annulus. So for this girl, we decided to use her venous P-valve. This girl had a total repair at the childhood, and currently she had a grade 2 and fro murmur, and echocardiography showed severe pulmonary regurgitation. The MRI demonstrated the dilated right ventricle and also severe pulmonary regurgitation. Here, these two videos show you the dilated right ventricle and the pulmonary artery morphology. Again, another video show the similar finding: the dilated right ventricle and severe pulmonary regurgitation. We did angiography, and which showed unstretched the pulmonary annulus diameter was 26 millimeter. And we also did the balloon sizing. The results showed that the stretched pulmonary annulus was 30 millimeter. We also confirmed no coronary dilatation, coronary artery compromise during balloon dilatation. And the venous P-valve, which is it is a porcine pericardium valve. The frame is composed of lightinol, and the diameter ranges from 16 to 36 millimeter. For this girl, we pick up the 30 by 25 millimeter graft, which means the diameter is 30 and the length is 25 millimeter. First, we pull back the outer sheath a little bit, and then conduct MPA angio to confirm the distal flare is located well at the LPA origin. Then pull back the outer sheath gradually, and you can see the fully expansion for this venous P-valve, and the final MPA angio showed a very good result. The case 3 is about the pull-stop valve. In addition to dilated right ventricle outflow tract, this lady also had LPA stenting because she had moderate LPA stenosis before. So for this case, we need to use another device, which is pull-stop valve. She also had total repair at 5 years old. She suffered from intermittent palpitation since 2010. She had CP stent, LPS stenting 2 years ago. The echoes and the MRI both showed moderate to severe PR. Here is the MRI again, show the dilated right ventricle, and the right ventricle ejection fraction still acceptable, is 48%. The angio show, you can appreciate the LPS stent right here, and the proximal part of this stent protrude into the bifurcation space. The balloon sizing showed the width is 25.9 millimeter, and the coronary artery okay. So we pick up the diameter 28 and the length 33 millimeter pull-stop valve device, and we deployed from the right pulmonary artery to avoid touch the LPS stent, but you can see the amazing angel. Now, when we advance the whole assembly into RPA, the LPS stent shaky a little bit, but we are lucky, the stent still here. And then we pull back the outer sheath a little bit and make sure the position is good. And then pull back the whole outer sheath step by step. Here you can see the whole stent expand very well. The final MPA angel confirm the very good function of this pulmonary valve graft. So so far we had 34 cases of percutaneous pulmonary valve implantation. All of them are successfully implanted. In the next slide, I will show you the midterm follow-up results for those patients with venous P-valve implantation. You can see the right ventricle and the diastolic volume index of all patients decreased significantly 6 months after implantation. And the BNP levels also decreased. And the functional class of all 15 patients all improved to the class 1 at 6 months after implantation. However, the maximum oxygen consumption during cardiopulmonary exercise testing of this group didn't improve significantly after the procedure. And from the right side figure, you also appreciate some of the patients, their right ventricle ejection fraction didn't improve after the procedure. So, ladies and gentlemen, I would like to make a summary. The first is PPVI is a good alternative of surgical pulmonary valve replacement for chronic postoperative PR associated with native RVOT. And the second is each device has its own characteristics. And the third is identification of subgroups who can really benefit from such PPVI procedure is a very important issue. Thank you for your attention. And please also save the date for the APPCS next year, which which originally we planned to have this conference this year, but right now we should postpone this conference to next year because of COVID virus. Thank you again.
Thank you, Mintai. So we proceed to next speaker and leave a question to the final part. Next speaker will be Professor Moria Shoda from Tokyo Women's Hospital, and he's now Japanese Society for Adult Congenital Heart Disease. He will talk about the arrhythmia intervention in adult cardiology, adult congenital heart disease. Professor Shoda, please.
Can you hear me?
Yes.
Yes.
Okay, thank you very much for inviting me to this important forum. So today I would like to present arrhythmia intervention in adult congenital heart disease. So as you may know, congenital heart disease are divided into 3 different categories. One is a simple congenital heart disease, such as PDA, pulmonary stenosis, BSD, and ASD. And the second category is a moderate congenital heart disease, aortic coarctation, anomalous pulmonary venous system, and etc. as shown here. And the Ebstein's anomaly may be associated with accessory pathway, such as WPW syndrome. And here is a severe congenital heart disease, trunks arteriosis, pulmonary atresia, and so on, as shown here. So in complicated congenital heart disease, the anatomy is also complicated and the conduction system is also complicated. So there may be very many variations of the complicated arrhythmias, such as twin AV node caused by atrial ventricular reciprocating tachycardia, and AV nodal reentry tachycardia in the abnormal AV node location, etc. But due to the expert consensus by heart rhythm, the catheter ablation may be the first-line therapy in patients with congenital heart disease plus complicated arrhythmias, because many antiarrhythmic drugs may be harmful to the complicated congenital heart disease, especially with diseased ventricular function. Unfortunately, it may be difficult for me to explain all arrhythmias complicated with congenital heart disease within 20 minutes. So today, I would like to focus on various tachyarrhythmias related to AV conduction system, especially in complicated congenital heart disease. At the beginning, I would like to talk about the catheter ablation of AV reciprocating tachycardia with accessory pathway and twin AV node. As you know, accessory pathway such as Kent bundle and Maheim fiber may cause the AV reciprocating tachycardia. But as you know, in the patient with heterotaxia syndrome and AV discordance, the patient may have twin AV node as shown here. So this patient may have AV node to AV node reciprocating tachycardia, which is one of the AV reciprocating tachycardia. So accessory pathway may be associated with the Ebstein anomaly, the AV discordant, heterotaxia syndrome, and other congenital heart disease. Here is the data from my institution, Tokyo Image Medical University, just published in Journal of Cardiovascular Electrophysiology this year. We have experienced 11 patients with accessory pathways in the atrial ventricular discordance, as shown here. I'm sorry, this is a very busy slides. But underlying cardiac disease and corrected transposition of greater arteries in 6 patients, DORV with SLL in 3 patients, and DORV with crisscross heart in 2 patients. This is an example of the patient with corrective TGA at the age of 10 years. Before catheter ablation, the 12-lead ECG presented the manifest WPW syndrome as shown here, panel A. But after catheter ablation, the delta wave disappeared. Panel A presented the AV reentrant tachycardia. The last 4 beats, we can see the wide QRS compressed with longer RR interval, which are called Kuhmer's phenomenon. This indicated the location of the accessory pathway should be left side. So because this patient had a normal superior vena cava and right atrium anatomy, we can approach the ablation site through the femoral vein approach as shown in the panel C. And we successfully ablated the accessory pathway by the radiofrequency application, and we could got the normal, narrow QRS complex without any delta waves as shown here. This is another example. The patient had DORV with crisscross heart. The patient was not adult, but young boys and 1 year old. The 12-lead ECG showed manifest WBW syndrome as shown in panel A. As well as accessory pathway, the patient had twin AV node as shown in panel B and panel C. When the conduction from the atrium to the ventricle goes through the anterior AV node in panel B and goes through the posterior AV node shown in panel C. And the panel D represents the site of catheter ablation. We can see the clear Kent bundle potential indicated by the black arrow. And here we apply the radiofrequency application, and the catheter location was shown in panel E. So after the first RF application, the Kent bundle conduction gone away, but the patient had still twin AV node, but we couldn't induce the AV node to AV node reciprocating tachycardia, so we decided to finish this ablation procedure. This is another example of the patient with corrected TGE and the post-double switch operation in the mustard and lustig. The age of the patient was 26 years. So we can see the AV reciprocating tachycardia shown in panel A. The anatomy of this patient as shown in panel B by Carto mapping and panel C in the angiogram. And the panel D represents the site of catheter ablation. The manipulation of the catheter is extremely difficult, but we could get the Kent bundle potential indicated by the black arrow between the V wave and A wave during the AV reciprocating tachycardia. After application of the RF energy at this site, the AVRT terminated promptly and VA conduction disappeared anymore. This slide shows the location of the accessory pathway in the 11 patients with AV discordant patient. Here is the results of catheter ablation. We could get the acute success in 100%, but I found the recurrence just in 1 patient among the 11 patients. There was no complication during the mean follow-up period of 11 years. And we could find the presence of twin AV node in 4 patients out of 11 patients. After successful catheter ablation, the cardiac surgery was performed in 8 patients out of 11 patients. Next, I would like to show you our data, the catheter ablation of AV reciprocating tachycardia with twin AV node. This is a schematic explanation of the twin AV node. We can see the two different AV nodes in the anterior side and the posterior side. And we can also see the swing between these two AV node systems. The twin AV node is very common in the patient with AV discordant and heterotaxy syndrome. Recognition of the AV reentry tachycardia due to twin AV node is not so difficult. We usually observe the two different QRS morphology without any pre-excitation, as shown here. In the upper panel, we can see the 2,3 AVF positive QRS complex, but in the bottom, we can see the negative diffraction of the QRS complex in 2,3 AVL, representing the at the bottom, the AV conduction was by through posterior AV node, which is located in the lower part of the heart. And in the upper panel, we can see the inferior axis, which means the location of the anterior AV node is the upper side of the heart. In all patients, we can see the two different His bundle electrograms as shown here. And the upper panel is the AV reciprocating tachycardia via twin AV node. Please note the QRS morphology is similar to the QRS complex at the bottom, because this AV reciprocating tachycardia mechanism where the antegrade conduction is a posterior AV node and retrograde conduction of the anterior AV node. If the reentrant circuit was a counter rotation, the QRS complex during the AV reciprocating tachycardia should be same as the middle panel. This is the induction of narrow QRS tachycardia in patients with thin AV node. When we apply the atrial extra-similar spacing at the left side of this panel, we can see the fusion beat of the QRS complex, which means anterior AV node conduction plus posterior AV node conduction. But the last atrial stimulation with S3 coupling interval 270, the QRS complex changed. The two AVL, lead 2 and lead AVF is a negative deflection mainly because the anterior AV node conduction was disappeared by the atrial extra stimulation, and this is only through the posterior AV node. This is the initiation of the AV reciprocating tachycardia with the antegrade conduction of the posterior AV node and retrograde conduction at the anterior AV node. Here is the ablation. So we decided to ablate the posterior AV node because these two AV node conduction are very strong, both in the anterior AV node and posterior AV node. But the manipulation of the ablation catheter to the posterior AV node is very easy, and then we apply the RF application to the posterior AV node. At right side of this panel, we can see the change of the QRS complex with the 2,3 ABF positive deflection of the QRS complex, meaning the anterior conduction is just only through the anterior AV node, as shown here. But we sometimes experience the not only twin AV node, but also twin AV node plus string. Here is an example of AV reciprocating tachycardia due to the twin AV node with string. If the patient has string, the QRS complex change are very minimum. So if I pace the high atrial pacing, main conduction through the atrium to the ventricle was through the anterior AV node. And if we pace the lower part of the atrial pacing, AV conduction through going to the mainly the posterior AV node. But as you can see here, the change of the QR complex is very minimized. The right panel of this slide, during AV reciprocating tachycardia through twin AV node with string. This QRS morphology is the same as the QRS complex during low atrial pacing in the middle. So the mechanism of this tachycardia is anterior AV conduction through the posterior AV node and string to the anterior AV node with the retrograde conduction to ventricle and the atrium. But as well as the standard type of the twin AV node, we can see the two different His boundary electrogram as shown here. Anterior side of the mitral valves and the posterior side of the mitral valves as shown here. But the characteristics of the AV reciprocating tachycardia with string is the very short, small windows of the resetting phenomenon, because the anterior AV node to the string and the posterior AV node, conduction velocity is very fast in comparison with ventricular muscle. So it is very difficult to reset this type of the tachycardia. And the excitable gap should be small. So characteristics of the AV node to AV node reentrant tachycardia with string is a minimal change of QRS between anterior AV node and the posterior AV node, and a narrow reset zone by premature ventricular stimulation. So finally, I'd like to talk about the catheter ablation of the bundle branch reentrant ventricular tachycardia. It is extremely rare tachycardia. We just have one case with corrected TGA with incessant bundle branch reentrant type of ventricular tachycardia as shown here. The age of the patient was 69 years. The anatomy of this patient as shown in the left panel. The position of the catheter, diagnostic catheter and ablation catheter in the middle, and the schematic explanation of the reentrant circuit of the incessant bundle branch reentry of the ventricular tachycardia is shown in the right panel. So during ventricular tachycardia, we apply the atrial stimulation as shown in the left panel. There is no QRS morphology change, as shown here, during atrial pacing during ventricular tachycardia, which is strongly indicated the supraventricular tachycardia or bundle branch reentrant tachycardia. But please see the middle panel. This is an intracardiac electrocardiograms during ventricular tachycardia. We can see the VA dissociation during tachycardia, which indicated not supraventricular tachycardia, but ventricular tachycardia. So our final diagnosis of such type of tachycardia was not supraventricular tachycardia, but bundle branch reentrant tachycardia. So we decided to ablate the right-sided bundle branch. And please see the right panel. We applied the radiofrequency application to the right-sided left bundle branch. And the bundle branch reentrant terminated promptly, just starting the RF application, as shown here. So this is my final slide. Today, I showed very complicated tachyarrhythmias in complex congenital heart disease. I think usually it is very difficult to cure such kind of tachycardia in complex congenital heart disease. But as I showed you in today's my presentation, if I performed the deep electrophysiological insights, complex congenital heart disease can be cured. So today I showed the data for all from my institution in Tokyo Women's Medical University and Shinshu University. Thank you very much for your attention.
Thank you, Professor Shoda. Now I would like to have now a Q&A part, because for the interest of time, 1 or 2 questions is allowed. Anyone?
May I ask Professor Shoda a question? Professor Shoda, and you have been talking much about the assisted pathway and twin amino in complex congenital heart. Do you want to comment some about the use of ICD for patients of tetraloid follow after operation, or some complex congenital heart with myocardial failure?
Oh, yes. In patients with bundle branch reentry, the ablation procedure is curative. But if a patient is tetralogy of Fallot and the other type of congenital heart disease with low systemic ventricular ejection fraction, I don't hesitate to use implantable cardioverter defibrillator. But as you know, many patients may have shunt to the systemic ventricle, systemic heart. So I hesitate to implant the transvenous ICD system to the patient with shunt to the systemic ventricle. So now we can use the subcutaneous ICD system. So we mainly implant the subcutaneous ICD system to the patient with congenital heart disease.
Thank you.
Thank you for your interesting opinions. I think that's very important, yes.
If there is no more question, then I will invite Professor Lin for the closure remark.
Because we are running out of time a bit, and I'll make a short remarks for this interesting webinar. In this webinar, we have Dr. Mahesham from Malaysia to give us talk about the VSD closure in adults, and for the also Dr. WorldCamp program from Bangkok to talk about the PDA and also the ASC closure in adult congenital heart. As you can see that when patients with congenital heart disease grow old, their problem get even more complex. For PDA, they may be calcification. For VSD, they may be resulting from the post-myocardial infarction situations. And also for ASD, the growing older of these patients, they are more and more patients with pulmonary hypertension. And the pediatric cardiologists, they did a very good job to fix these patients' problem and bring them back to the normal physiology with the help probably with drugs to control the pulmonary hypertension. And also for severe PI in patients with tetralogy followed or the transposition heart, they can have a big problem, right ventricular failure. And the cardiologists in pediatric field, they can have implant the artificial pulmonary valve through percutaneous procedure. And they can also bring the right ventricular pressure, right ventricular function back to normal. Finally, with the very complex arrhythmia in patients with complex congenital heart disease, Professor Mario Shota showed us that by cath separation and with the understanding of the abnormal pathology and also with understanding of the physiology component for electrophysiology, we can operate these patients or patients with a twin amino or with acid pathway in abnormal location in complex congenital heart. But still, we also have the problem of these patients of myocardial VT. They may need some ICD implant. And Professor Shota showed us that maybe the subcutaneous ICD is a kind of choice. And this is the conclusion of my closing remarks. Thanks for everyone to attend this interesting webinar talking about intervention paradigm in adult congenital heart disease. Thank you for your attendance. Thank you very much. Thank you.
Thank you.
Okay. Bye-bye. Welcome. Okay. See you all. Thank you.
Thank you. See you next time.
A few words.
Yes. Yes. Professor Lu is going to give in another closing remarks. Yes.
I enjoyed very much this so-called crowd forum, which was organized mainly by Professor Lin and our president, Jack Tan. It's wonderful at this time of COVID pandemic. Thank you very much.
Thank you. Thank you all. Say goodbye.
Bye.
Okay. See you all. Okay, cool. Yeah. Okay. Okay. Now, okay. Okay.